What percentage of people with Sezary get a second malignancy and how long after diagnosis? In addition to that, is there an updated life expectancy with Sezary?
I love the second question, and I wish there was, because it's certainly not what you would see if you looked on the internet. So don't even look because it's so far off of reality at this moment. But secondary malignancies, all patients who've had a diagnosis of lymphoma have a slightly higher incidence of other lymphomas. They don't have to be T-cell lymphomas, and they don't have to be skin lymphomas. As well, there's been quite a lot of epidemiologic studies looking at patients with cutaneous T-cell lymphoma that suggest perhaps an increased incidence in certain malignancies like colon cancer. All patients with lymphoma have an increased risk of kidney cancer and melanoma. But there's no, the risk is not hugely great over the general population. And there's no period of time with which you would be concerned about secondary malignancies. In fact, the secondary malignancy may precede the diagnosis of cutaneous T-cell lymphoma.
It's really good information. Thank you.
Can I ask a
Dr.
follow-up
King?
question? Do you have recommendations, Dr. Pinter-Brown, about how to monitor for such things?
I think really with history and physical exam, I definitely wouldn't advocate screening with radiographic studies like PET scans or CTs. I think that in a patient who has lymphoma, any complaints that sound like what we call B symptoms, fevers for no good reason, profuse sweating at night, or a significant weight loss for no particular reason, lymph nodes that could be felt or seen, should be pursued. And certainly any skin lesion that looks like melanoma, that's true for anybody, though, really. We wouldn't, just kind of pass it off. But other than the person being aware of their symptoms and communicating them to a physician, and their routine physical exams, which they're going to get because they're being seen by a physician, I wouldn't advocate anything else, including blood draws.
What treatments are available for cutaneous T-cell lymphoma Sezary with TP53 deletion?
That's a good question. So if we look at TP53 deletions across the board in lymphomas, B or T, the message is that conventional chemotherapies don't work so well. And thankfully, we don't use conventional chemotherapy very often for cutaneous T-cell lymphoma and specifically for Sézary's. So I would utilize the knowledge about a TP53 mutation in the same way that I do for other lymphomas, and that I would tend to use therapies that aren't conventional chemotherapeutic agents.
Have you had any experience with Sezary syndrome causing memory loss as it progresses?
So Sezary syndrome itself is not often known to cause memory loss. Having said that, I think as things progress, there's as all of you know, there's a lot of other things that go into this having Sezary syndrome, and many patients will come in with a flare where they're itching beyond the ability to be, their suffering to be minimized, and then their sleep deprivation and the like. There's also, as you all know, a number of the medications that we use for itching, and all of those things can make people sleepy and can have challenges. Patients often talk about word finding issues as the first challenge, but I think that it's a multifactorial thing in terms of, is it the treatment? Is it some of the side effects of the treatment? Is it some of the side effects of the disease? All of those things come into play.
For Sezary syndrome, erythroderma and blood involvement, with so many treatment options, how does a doctor determine whether to treat a patient with a single treatment option or a combination of treatments? Dr. Dreher, do you want to start us off?
Yeah, this is a great question. I think that as we've evolved and learned as physicians how to combine therapies, we've become quite good at it, where we can take different therapies with non-overlapping toxicities. That means they work well together without increasing side effect profiles. And then years and years of real world use, including formal clinical trials, but also what we say as empirically understanding and acquiring experience in the field. So with ECP or photopheresis, we often combine that with other modalities. One of them would be oral targretin, the pill, a retinoid, and it works quite well. And patients tend to do well when they're on both. Sometimes we also add an immunostimulating agent like interferon injections. There's both an alpha type and a gamma type, and we've used both. And sometimes we use all three, something we call triple therapy that seems to really synergize when they work together. And then there's kind of sequential therapy. So we might start a patient on photopheresis, keep a patient fairly well controlled for even a number of years, and then the disease may advance. And then we work with our colleagues in oncology, including especially Dr. Foss and Dr. Sethi here, and they may get a modality such as mogamulizumab that might knock down the counts in the blood, and the patient again becomes eligible for a more gentle treatment such as photopheresis and oral targretin. So, we work starting patients on combination, but also we do it sequentially fairly often.
I just
Dr.
wanted,
Sethi,
I just wanted to say one thing, and that is that we work very well as a team. And generally speaking, Mike, who runs the photopheresis center, sees these patients first, and many of them are candidates for this kind of immunotherapy, not exposing them to chemotherapy, if they can respond very well to biological modalities. But sometimes a patient comes in, Tarsheen and I both see these patients that come in with very, very aggressive disease, perhaps with very bulky lymph nodes that we biopsy that show transformed or very aggressive disease, or they come in with Sezary syndrome and lots of cutaneous tumors, very bulky disease. They're very sick. And those patients sometimes have to move directly into chemotherapy. Tarsheen has done a lot of work with some of the single agents like brentuximab, mogamulizumab, and perhaps she can speak a little bit about that. I see these patients when they're more advanced and we start thinking about transplant. We start at least talking about transplant. Even if they're perhaps going to go on one of Tarsheen's single agent modalities, we still at least have that discussion in case that comes up in the future, and it does for many of these people. So Tarsheen, you've had a lot of experience with single agent therapies for these patients. What are your thoughts?
Yeah, absolutely. I do think that we always get started with single agent, and especially in patients who do not have that rapidly progressive disease. Again, oftentimes for Sezary syndrome, mogamulizumab is our first choice. Pralatrexate is another drug that is effective, for this particular this particular compartment of disease, this particular presentation of CTCL. But like Dr. Fuss alluded, for more rapidly aggressive disease, especially patients that we want to get a deeper response for transplant, we sometimes move on to more intensive chemotherapy-based combination options.
I have B2 Sezary, and I'm being treated with bexarotene, interferon, and phototherapy. I hear about ECP and mogamulizumab and wonder if I'm getting the best standard of care available. How do I know? Also, I've been told bexarotene may take up to 9 months to work. Is this the case in your experience? So, Dr. Jardy, you just talked about ECP. I don't know if you want to add anything additional to this question, and if the rest of you want to weigh in on the rest of it.
Yeah, I'll jump first and say, with B2, more blood involvement in your disease, I think that you were appropriately treated with combination therapy, including photopheresis. And like I said, we do often combine that with oral bexarotene, targretin, and interferon injections. And we will also use phototherapy as well to help get those lesions in the skin. So again, getting disease from the inside outside. So that seemed very appropriate. Combining mogamulizumab with photopheresis, I think the data is coming in that they're very compatible and may offer, again, a way to combine treatments to treat more aggressive disease, especially with blood involvement. Oral targetin can take 3 months to work, 6 months to work, 9 months to work, 12 months to work. It really is patient to patient, how high we can get the dose up safely and what other combinations are being used. In general, as long as we're keeping disease under fairly good control, it's not progressing. That's goal 1. Goal 2, we see decrease in disease, skin improving, blood counts going down, and then we feel better again. And then, reaching for that 3rd level resolution. So we don't always get to resolution. Sometimes we're satisfied with getting disease to be maintained at a certain level where a patient can live life and do all of the things, or at least most of the things they want to do in life. And if we can prevent progression for a long period of time, then that's also a way we can feel at least partially successful in keeping this disease under control.
I think another important point, getting to what Mike just said, is that there are different compartments of disease. So there's the blood compartment, the skin compartment, and also the lymph node compartment. So when you think about yourself as being, say, a B2 patient, you have to think about the whole picture. So what seems to be an appropriate treatment for one B2 patient may or may not be appropriate for another one. And as we move forward with the treatment, we look for response in all of those different compartments. So I think it's really hard to extrapolate from one person to another without looking at the whole picture. And I think these are very good questions, and that brings up the whole point that you should be talking with your physician about these questions, and don't hesitate to bring this up, to get into a discussion and ask, well, why this and not that? Because I think, anybody treating this disease, any of our colleagues that you might be seeing would be really happy to help you to answer those questions.
For Sezary syndrome, is mogamulizumab best by itself as an individual treatment, or is it better as a combination treatment concurrently with, say, ECP? Dr. Sethi, would you like to answer that one?
Sure. So, the way that mogamulizumab was studied and the way that we have the most data for is to use it as a single agent. But again, as Dr. Girardi mentioned, and as I mentioned, some of the other centers are looking at the combination of ECP and mogamulizumab. And really what we are trying to see is that can we maintain a response that we achieve, for example, with mogamulizumab by using going back to ECP, for example. So that I do think that currently standard of care is to use it by itself, use the mogamulizumab by itself. But I think we are really moving to see how we can extend the responses by using a combined modality.
What is the most important thing to review for a Sezary syndrome's patient when looking at our flow cytometry report? Should I be looking for anything specific CD positive or CD negative markers? So who would like to take this one?
I can start with that one. So because of ability for patients to now see their charts and see all these details, what many patients will see are all the different CD markers that get done for the flow cytometry. The flow cytometry involves basically staining the lymphocytes with different markers for CD2, CD4, CD26, et cetera. And then looking at the percentage of cells that express those markers. And sometimes they're looking for 2 markers at the same time or 3 markers at the same time. So what you'll see is all these different numbers, lists of numbers. In many centers, they don't actually give you the interpretation either. So in our center, we get the report with all the numbers, but then also we get an interpretation that says something like 26% of the circulating lymphocytes are Sezary cells. So that kind of gives us a number to hang our hat on. There are specific markers that Sezary cells have, typically CD4 positive and CD7 negative, but sometimes that's not always the case. Sometimes they're identified based on other markers. So it's a little bit tricky if a patient is actually trying to look at this data and figure it out. I mean, Mike does a lot of work in his lab with Sezary cells and looking at markers. I don't know if you had any advice for patients, Mike?
Yeah. First of all, it's a challenge to interpret a lot of these numbers for a patient, and I think so. Trust your doctor to interpret them. But if you want to really zoom in on a couple of numbers, I think one is the CD4 positive, 26 negative. CD4 positive, CD26 negative is one of the most reliable markers for abnormal cells in a patient along the lines of a CTCL phenotype. You have to understand that you can have 10%, 12% of your T cells that normally have that CD4 positivity, 26 negativity. So that's why really understanding on how to look at that. That's one number that, along with loss of 7, can be very helpful. The CD4-CD8 ratio can be very helpful. A normal patient is around 3.5. A CTCL patient with blood involvement might be upwards of over 5, over 10. And so seeing that gives you information about involvement with abnormal CD4 cells, but also how well your immune system is doing otherwise. That is the CD8 compartment. The CD8 compartment is typically not a phenotype we see in patients with mycosis fungoides or Sezary syndrome. So that ratio where we have a CD4 over the CD8 can be very informative in two directions. So I find that to be particularly helpful, and I pointed that out to patients. That's something they can look at and follow over time to see how healthy they are in terms of the CTCL and their immune system. We do some other second-level analyses at Yale. We do a V-beta analysis, which can look at expanded populations within a profile of T-cell receptors on CTCL cells. We can also do cytogenetics. I've worked with genetics to institute a cytogenetics panel that is more specific for CTCL, as is the case with other leukemias and lymphomas. So we have that available to us at Yale as well to help really understand the degree of involvement, but also some of the genetic mutations that are present.
What have you found as your most successful ways to treat Sezary at this point?
So this is a very nice question. So actually, I wish Dr. Glass is here. He can tell you experience before MOGA and after MOGA. I really after mogamulizumab really changed how we look at the disease process of Sezary syndrome. So the way we treat disease, as many of you guys know, the reason that we never really achieve CR in cutaneous T-cell lymphoma is that when we grade the response, we grade it based on different compartment, right? You can have the response in the blood, you can have the response in the skin, and you can have the response in the lymph nodes. And different drugs actually have different efficacy in each of the compartment. And in Sezary syndrome, we say the reason people are itching red on like top to the body is not because of there's a lot of cancer cells in the skin. It's because of there's so much cancer cells in the blood. It's secreting cytokine to make patient all red and puffy. And the reason is because of sometimes if your dermatologist take a skin biopsy and they miss the diagnosis of Sezary syndrome, it's not their fault because there's very little cancer cells there. So sometimes Sezary syndrome is harder to diagnose in a skin biopsy than mycosis fungoides. And the reason I'm saying mogamulizumab really changed the paradigm of this is that mogamulizumab actually caused, even though the overall response is not very high, like you saw the slides about 30%, but in my experience, like almost 90% of patients will have a good response in their blood, and especially when they have MOGA related rash, like they really have a great response in their blood. Then what we're dealing with is, again, the disease in the skin, right? And that's hard to treat. That's harder to treat, in my opinion, than the disease in the blood. So then, we do a lot of skin-directed therapy. We use additional chemotherapy. The large cell transformation was the hardest, in my opinion, in the treatment paradigm here. So for the Sezary syndrome patient, I say the treatment are based on, like, the initial treatment, how I treat it, are based on two things. One is the burden of the disease. If you have very little, not a lot of burden of the disease, we usually start people with ECP. And if their disease are like a lot of burden, then we start with ECP and then potentially add, I guess before MOGA time, we add interferon or targretin as the treatment to augment that disease. But now, since I know if I give, a cycle of mogamulizumab, I'm going to clear the blood, I usually jump in directly to mogamulizumab.
And I think there is a study, MOGA ECP together right now ongoing. Yeah, so that's probably a good study, mogamulizumab and ECP together. So clear the skin and clear the blood,
What is a recommended path to stem cell transplant with Sezary beyond being as clear of cancer as possible?
So, I have not done a lot of stem cell transplant for Sezary only in this in this time period. It's because of a lot of treatment that we have changed the paradigm for the Sezary syndrome. But sometimes when Sezary syndrome patients develop large cell transformation and they develop multiple large cell transformation, that's when we think about allogeneic stem cell transplant in those particular case, because we know they're very hard to get to a complete remission with the current available therapy we have. Other than, the goal is always a complete response. So sometimes we use chemotherapy, sometimes we use total skin radiation. But to be honest, getting a complete response in CTCL is very difficult, and having that response to last more than 6 months is even worse. So what we usually do is we give them some therapy to get to a partial response, and then right before, remember I said the blood is easier to clean out now, and the lymph nodes we can clean out with chemotherapy. The issue was the skin disease is very hard to control. So we'll do a total skin radiation like a couple of weeks before the stem cell transplant to get them into theoretically a CR before the transplant. But for Sezary syndrome only, say if they don't have large cell transformation or significant disease in the blood and they respond very well to the therapy that they're on, we usually do not do transplant right away.
So the patient, should have a disease that is refractory and now in complete remission, and we do not expect this complete remission to last for a very long time. That's why we would probably take him to transplant. And also he should have a donor. So finding a donor sometimes is an issue. That's part of the path into an allogeneic transplant.
Yeah. And we consider it for younger patients sometimes a little bit more, just because of their ability to tolerate the transplant, and also we're hoping for a cure, really, for younger patients.
What are some of the most effective medications or infusions for Sezary syndrome?
So Sezary syndrome, for everybody else who is not that familiar with Sezary syndrome, is a form of cutaneous lymphoma where we have significant involvement of the blood compartment, and usually also a significant involvement in the skin, where the skin is usually very red. We call that erythroderma. So for that therapy, as it encompasses usually at least the skin and the blood compartment, purely skin-directed therapies are usually by itself alone not adequate, and we go to systemic therapies. We have, thankfully, now several therapies that are quite effective for Sezary syndrome. And it really depends on where you are being treated, what the preference is in terms of sequence. It has also to do with how much blood involvement there is. For example, we categorize it as B1 and B2. B2 is usually Sezary, but there it can also vary. We can have low B2 and high B2. But in terms of IV systemic therapies for Sezary syndrome, the preferred agent at this point in time is mogamulizumab, which is a monoclonal antibody against one of the proteins that we usually find on Sezary cells, called CCR4, and that can be very effective in clearing the blood compartment. It also is effective in treating the skin and the lymph nodes. It can be sometimes used, for example, in combinations with other modalities. It can also be used, for example, with other systemic therapies in combination, and there's a lot of interest in terms of clinical trials. How can we enhance the activity of mogamulizumab? There are other therapies as well in case mogamulizumab is not the right treatment for the individual, and that would include, for example, histone deacetylase inhibitors or HDAC inhibitors. One of the examples of that is romidepsin that is commonly used. And these are probably the most common drugs that we initially use for Sezary syndrome. There are a couple of drugs that are also have gotten very, very far along in clinical trials, and hopefully will be available in the future. And there are several other drugs that can be used, although the HDAC inhibitors and mogamulizumab probably have the most activity for Sezary syndrome and the blood compartment.